Hi guys, welcome to this three-part knee series for fitness coaches. Thoughts of a physiotherapist. I'm Bryan Robertson. I'm a physio in Melbourne, Australia. I've developed a special interest in knees and knee injuries over the last 10 years. And this is a three-part series that will enhance your knowledge and applicable skills in terms of observation, visual assessment, anatomy, and impact standing of your programming. The three webinars will include, number one, detailed anatomy of the knee. It's not just a hinge joint. Number two will be the X-ray vision superpower. So looking at the outside, what's actually happening on the inside, specifically in movement and functional movement. And then in the third one, that will be more of a open Q&A with a bit of explaining your knowledge to your clients. I hope you enjoy it. Just a heads up and a couple of disclaimers. Number one is I'm not too concerned about the production quality of these. You'll see some of the videos are taken in clinic. I'm sitting at home during COVID lockdown. So just thought that I'd share a lot of this information. So the production quality might not be amazing, so forgive me for that. The second thing is a lot of this will really question textbooks and really question what you see on the internet. The reason why I'm doing it is because we need to progress beyond just simple anatomy textbooks, anatomy drawings. I'll explain a lot more as we go, but hopefully you enjoy this video webinar series. Okay guys, so let's start with typical anatomy textbooks. I'll show you here, once you Google knee anatomy, plenty of different pictures come up, plenty of different sources, plenty of different drawing styles. We'll start with the basics. The femur and the tibia come together to form the knee joint. And then you'll see we definitely speak about the patellofemoral joint as being completely separate. So really the knee joint comprises two separate joints. We won't talk about where the fibula attaches. This is mainly focused on where the femur inserts into the tibia, and then you've got that kind of second joint of the patellofemoral joint. So a few really good sources. WebMD on this one is not too bad. You can see a lot of the ligaments and tendons are quite separate. You can see here where the kneecap, the patella, is completely separate to any of the adjoining structures. These are not bad and a really good basic setup. Some of them are better than others in terms of production quality and plenty of different options for you to go through. I'm not going to run through the complete basics based on anatomical textbooks. I expect that that's something that you can learn. What I am going to focus on is how the knee in real life actually differs to these textbooks. So a warning about some graphic images. We will go through some cadaver pictures because it's a really good way to actually see what's going on within the knee. We're not going to work through imaging at all in these three-part series. I potentially will do that in the future with a radiologist. So let's start with a cadaver. This is an anterior view of a flexed knee, which is an excellent thing to have a look at. You can see that this is the lateral aspect of the knee where the IT band comes down and attaches onto Gertie's tubercle. You can see where the patella is, the medial femoral condyle and the lateral femoral condyles are exposed. You've got the medial patellofemoral ligament and three different portions of this. And then the medial meniscus is documented there as well. So that's quite a good front-on view in about 80 to 90 degrees of flexion. Have a look at this lateral view here, where you've got the newly found anterolateral ligament. You can see the popliteus tendon, the lateral collateral ligament as well, and the fibular attachment of that is documented by the orange pin head. There's plenty of other really good cadaver pictures of the knee. This is a decent one that is from the posterior. No, sorry, this is from the anterior aspect. And you can see the patella and the patella tendon has really been flipped over in that cadaveric knee. Here's another great picture here where you can actually see the articular cartilage being that really, really white stuff above the LM, lateral meniscus. And this is just a really good view of that complex on the outside. And in terms of knee anatomy, the biggest thing that I want to show you here is that the thickenings, the ligaments, you can see the star, the circle, the diamond, they are all really thick thickenings of the knee. So if you have a look overall, let's go into this one here. The whole bunch of white stuff in this picture here just shows you exactly what a knee looks like. All of those thickenings, those ligaments, are actually just thickenings of the entire joint capsule. And that's super important to know because they don't exist like this in an anatomy textbook. It's actually just a thickening of the entire joint capsule. Okay, so what we're using today is complete anatomy. This is a right knee that we're looking at front on. And what I'm going to do is just remove a lot of the layers of muscles. We're not going to go through the muscles today, but we're merely going to focus on the joint of the knee. So once you remove all of those layers, we're going to just spin around. You can see the lateral side of the knee, posterior aspect of the knee, and then anterior. So let's work our way down. Let's remove a layer of fascia. So just exposing that femur and the tibia. Now, the most superficial things that we've got here, and you can see the pre-patellar bursa, subcutaneous, so just underneath the skin, but on top of the kneecap. You've got the infrapatellar bursa, you've got the deep infrapatellar bursa, and then you've got a suprapatellar bursa. So we'll leave those there. Let's take a look at the medial aspect of the knee. So you'll see in the surface anatomy where we go through, especially on CAM in clinic, we'll discuss the medial collateral ligament, the patella tendon. And so with the medial collateral ligament, you can see this, what they call the tibial collateral ligament here. And I'll just try and zoom in a little bit more. Overlying that is the anserine bursa, where the pes tendons come down and insert onto. But what I'd like to point out here is you can see that this MCL is just a thickening of the entire joint capsule. You can see another bursa through there, the semimembranosus, which is where the hamstring comes down and inserts over. I'll also point out now this medial patellar retinaculum. Deep to that, you've got the medial patellofemoral ligaments, and as I said before, that articular capsule of the knee joint. Let's just spin around and have a look at this lateral aspect. Now you can see there's a lot of different ligaments that connect everywhere. It looks very, very different to what you see in the anatomical textbook, when most of the time they just point out this lateral collateral ligament. You can see the patellar retinaculum, and that patellar retinaculum is actually quite thick. If you then go more posteriorly, you can see, this lateral collateral ligament is it's actually tiny in terms of percentage of surface area. And again, it's just a thickening of this capsule of the whole entire knee joint. You can then see this arcuate popliteal ligament. You can see the actual oblique popliteal ligament. So significant posterior structures. Again, those are just continuations of this and thickenings of this whole joint capsule. And then as you come around again, you've just got the joint capsule everywhere. So let's go a layer off. I'll zoom out a little bit. And this is exposed quite nicely, that anterior aspect of the patella. And you can see here this medial PFL and the lateral PFL as well. Very strong ligaments that you very rarely see in textbooks. Let's go another layer deeper, and one more again. And so this exposes the synovial membrane of the knee joint. Now, a lot of the time I utilize a water bottle analogy. This synovial membrane of the knee joint covers the entire capsule. However, you can see that these cruciate ligaments, the posterior cruciate and the posterior meniscofemoral ligament, are outside of the synovial joint. That has certain implications for when this gets ruptured compared to when the anterior cruciate ligament gets ruptured. But just know that this whole knee joint is what I like to explain like a water bottle. Is if the water bottle is filled up with fluid and has a tiny amount of air, you can bend that water bottle with a bit of force, right? But after, say, a surgery and in particular an ACL reconstruction, it's like that water bottle fills up with fizzy Coke, which is bleeding and hemarthrosis. And what happens is that Coke and fizziness, it's like the bottle's been shaken up. And if you try to force it and bend it, because of the intracapsular pressure, you're not going to get much movement. And that's why during physiotherapy in the initial stages, you'll see that there's a big restriction in movement, especially post-ACL reconstructions. So let's go another layer deeper, and you can see this is where that internals of the knee joint is exposed. Now, the meniscus is absolutely key, and you'll see we'll go through this with some of the models that I like to show clients, and it's just good to get a different point of view. But the lateral meniscus sitting on that lateral aspect, you can see the medial meniscus of the knee joint, and this tiny transverse ligament sits at the front of the knee. Most of these things you can't feel, you can't see during the surface anatomy. We'll keep it super basic, but you can see the anterior cruciate ligament that comes up and inserts onto the lateral femoral condyle, and it goes through into the anterior, probably anteromedial part of the tibial plateau. And then what happens when we get rid of everything else? You can then see the articular surface of the femoral condyles, and you'll see a really good picture when we can flip open that patella, and you'll see the articular surfaces of the patellofemoral joint, and then here's the articular surfaces of the tibia and the tibial condyles. So hopefully that gives you a really good overview of the anatomy and the anatomical structures of the knee from a physiotherapist perspective. Don't worry, there won't be any tests or anything. You don't have to remember the names and the orientations, the origins and the insertions of all of these things. The main thing that this will hopefully give you is an increased knowledge base to then go into the next phases of these webinars. So we're going to take it into clinic and we're going to go through some surface anatomy. We'll keep it really simple. And then the next steps is we'll go into some functional movements. Join me next week when we release the X-ray vision of the knee. So in particular, what movements, and mainly being the squat, but what movements are happening within the knee during exercises that we would prescribe every single day, and why is it important to know those movements of the knee. Overall, it's not just a hinge joint. It can be very complex, and hopefully you've got some decent knowledge out of this going forwards. Let's head into clinic and continuous surface anatomy. I'm going to use Cam Steptoe, our physio, who will be on a future, hopefully, shoulder podcast. Going to go through surface anatomy to start with, and then I'm going to do a bit of video assessment. I'll show you what it looks like on Cam's knee during those movements, and then the so what principle, like what does it matter if he's got valgus, what does that look like? And then in the second installment of this series, it'll be the X-ray look. So basically deep inside look at what is happening during those movements and so what. Like what do we need to be concerned about? What don't we need to be concerned about? Let's get started. Normally I'm very good at this, but this is like take 3. Okay, so anterior knee, you're looking at the patella and then the patella tendon right across through there. Tense your quads for me, Cam. You can see these two mounds either side of that patella tendon. Usually that is Hoffer's fat pad. If there's no inflammation, that patella tendon, usually that is Hoffer's fat pad. Okay, Hoffer's fat pad. Now we get to this. We've gone through all the anatomy. I've shown you heaps of Google stuff. We've gone through a really cool anatomy program and not one mention of Hoffer's fat pad. Cool. Let's go through this. I'm going to share my screen. What is Hoffer's fat pad? Well, if you have a look at this, it's the infrapatellar fat pad, right? You have to Google it and you have to search for it, because I went through a full physiotherapy degree and I think it was probably mentioned once. Yes, I was a bit hungover in a lot of our wet labs, but this is something that is so important that really isn't taught very well. So if you have a look underneath the patellar tendon, but in front of the meniscus, you've got this significant fat pad that sits and takes up a significant amount of space in the anterior knee compartment. If you have a look at the cadaver model, these all show a significant amount of the fat pad taking up, I would say 25 to 30% of the anterior knee space on an MRI by cross section. And so when you have a look at this, and this is a really good picture here, this number 1, that Hoffer's fat pad is huge. You actually don't realize this until I've been very, very lucky to observe surgeries and be in surgeries and go through and have a look from inside the knee. Let me show you what this looks like. So this was a cadaver wet lab, and I'm going to take you through and show you that Hoffer's fat pad, that bright yellow thing right in the middle of the picture. What I've done is I've popped a circle in where this patella is, and the 2 lines down either side of that fat pad is where the patella tendon was. Now what we've done here is we've actually harvested a graft for an ACL reconstruction using the middle third of that patella, and you can see the two holes in the bones. The upper hole is the patella and the lower hole is the tibia. But it just gives you a really good indication to show you that that Hoffer's fat pad is very, very large. It takes up a significant portion. It's only exposed because we've removed that patella tendon. But what a great view. Swelling and then relax, that's good. Do that again. I just want to show you what happens to the actual tibia. Contract and up, good, and then back down. And we'll go through this. This is that locking mechanism at end of range, which sometimes people can't get. Yeah, cool. Then when we're looking at the knee, medial, usually the medial joint line or the medial collateral ligament is a significant source of pain, or the lateral joint line, lateral collateral ligament, which is really focal in through there. Just remember that you've got your IT band that comes down and fans and attaches onto patella, onto your tibia, onto the fibula head as well. But some other structures that could be involved is hamstrings. This is the biceps fem tendon, is pretty large and connects onto that fibula head, as well as, and we'll go through this in the X-ray vision webinar in the next series, is that this will actually flare and join into a lot of the other structures in that lateral side of the knee. So very rarely it's just one point that's at play. And so really important for you guys, know that that's lateral, know that that's anterior, know that that's medial. And then at the back of the knee, the posterior aspect, you've got the gastrocs that are inserting up above the knee line, and then you've got the hamstrings that are inserting down below the knee joint. There's a whole bunch of significant structures in through here that we'll go through in the next webinar, but really important for you guys just to give a good overview of where that pain is to the physio or whoever you may send them across to, anterior, medial, lateral, posterior. Okay, so let's go into this IT band into more detail. We're looking at the lateral aspect of the knee here. And in terms of this lateral patella retinaculum, you can see that it covers a significant portion with a whole bunch of different orientation of fibers between the femur and the tibia. Now, what I'd like to show you is, let me make sure that we're sharing the right screen here. Yeah, here we go. So what I'd like to show you is that this IT band, as you can see here, which has had some of the fascia removed, and this biceps femoris tendon, you can see a lot of these fibrous connective tissues that run in all different directions. And so there is a definite connection between that biceps fem and the IT band. And you can see some of these fibers through here and this connective tissue on the top. And the other thing that I'd like to show you is that fanning that I'm talking about of this IT band, you can see that it comes up and attaches onto the patella, goes down and inserts into Gertie's tubercle on the tibia. But then also there's these connective bits of tissue in between. So that's a really good view there. This is another one where you can see the vastus lateralis, the superficial IT band. They've kind of put a circle around that, but you can see these connective tissue, which they call the superficial oblique retinaculum, and then onto Gertie's tubercle as well, and then another one here as well. So you can see that there's this fanning, and it's super important for you to know that that IT band and anything that inserts into that fibula head, it's not just one specific structure. So I hope you've enjoyed part one, the detailed anatomy of the knee from a physiotherapist. Hopefully this just increases your knowledge around what structures are being affected, especially when a client will explain to you pain or discomfort in a particular area. Now, in the next 2 webinars, what we'll do is we'll go through the function of the knee, what's actually happening deep inside, what I call the X-ray vision of the knee, and just really important to understand that the knee isn't just a hinge joint. There's a lot more to it, and hopefully we can get, in particular, our squat technique or our split squats or lunges, we can get a really great understanding of what's going on deep inside this amazing joint. Thanks. Hope to see you next week. Okay, so we're going to separate the knee into 2 different joints. The first one being the patellofemoral joint. For simplicity, we're going to take that out. People will tell you that it is a hinge joint and it does flexion and extension. If that was true, this is what would happen. That femur would roll off the back of the tibia during any flexion. So there's 2 aspects of the knee joint. Number 1 being the accessory movements. In order for the knee to work really well, you get an accessory movement, and I'll separate this here, of an anterior glide when you go into flexion. So instead of just being a complete flexion, there's actually a flexion but an anterior glide at the same time.